There are questions even before we start.
I have actually received some questions on email as well. Okay, so this is, I think it's a good time to start. So, my name is Dr. Prasad Dandekar. I'm a radiation oncologist based in Mumbai. And welcome everyone. Thank you for joining. We already have around 117, and as I speak, the numbers are increasing. People participating, more than 400 people have already registered. What we wanted to discuss today was very relevant to the times that we are in. As the COVID crisis is deepening in India, we are all really struggling about how do we treat our patients and how do we manage their oncological safety as well as safety from the point of view of infection. So it was very interesting that end March, this paper, fast forward paper, got published, and we all sort of got very excited. And that's when we realized that while we are very excited about this new paper and treating patients with this protocol, we also don't want to swing it the other way around, that we actually sort of misuse these protocols and treat the wrong sort of patients or treat them in the wrong manner. And that's where this concept came, where I thought Sanjay, Rima, and Santam have excellent experience in treating patients with hyperfractionations, and it would be wonderful to get all three of them together on a platform and tell us what to do and what not to do. So that's the whole concept of this webinar. We will, of course, take a lot of questions towards the end. So as I said, please paste your questions in Q&A sections and we will take them at the end. We would definitely, we would like to request that we would avoid questions which are related to COVID treatment or PPE related questions, because that's sort of not in the purview of this discussion. We'll focus our discussion on breast cancer treatment only. So I would like to introduce our panel. Dr. Sanjay Chatterjee is consultant in Tata Medical Center, Kolkata. Dr. Santam Chakraborty is also consultant in Tata Medical Center, Kolkata. And Dr. Rima Pathak is consultant in Tata Memorial Hospital, Mumbai. None of them need any introduction. All of you know them very well. So I'm going to directly jump in and request Rima to take over and start the session. Thank you.
Thanks, Prasad. I'll just share my screen. I hope you're able to see it.
Yes, we can see we can see the slides.
Can you see my first slide?
Yes, we can see your first slide. Yes.
Okay, and does it scroll down?
Yeah, it is.
Okay, so I think we're good to go. So thanks, Prasad, for the wonderful webinar and a very nice and very relevant topic in these days. So I'll be basically taking you through the nuances and Indian perspective on ultra hypofractionated radiotherapy in breast cancer, and talking about inclusion, exclusion criteria, contouring, and planning guidelines that were used in these studies. Now, we all know that there's level 1 evidence for using moderate hypofractionation, such as 40 gray in 15 fraction and 42 gray in 16 fraction. However, in a recent survey that I had conducted, I saw that there was the uptake of moderate hypofractionated regimen, either of these two, was only about 70%. And it brings us to wonder, in these troubled times when most of the international guidelines specify that you could treat these patients with high fraction, limit their hospital visits by using these ultra hypofractionated regimen, the anxiety levels for all the radiation oncologists would be fairly high. And through this webinar, mostly we would try and alleviate a few of those anxiety issues. Moving forward, this may be a confusing slide, but we should be able to go through it. And here we know that the safety data from all these studies permit use of 5 fraction of treatment during the COVID outbreak, and that's why we're having this webinar. This particular diagram over here shows, so this slide is Dr. Sareen's slide, and he's kind enough to give it to me. So it just shows the interplay of various fractionation comparison between all of these studies. We all know that the START B study had 40 gray in 15 fraction and was compared to the then standard 50 gray in 25 fraction. And while we had early results from START A and START B showing the alpha by beta to be between 3 and 4, it was conceptualized that we could perhaps use this alpha by beta in our advantage and further try and hypofractionate the treatment to treat in 5 fraction. But at that point in time, the standard was still 50 gray in 25 fraction. And hence here you can see on the bottom left that the FAST study was compared with 50 gray in 25 fractions. And here the FAST study was conceptualized again to be treated over 5 weeks, keeping the time of treatment similar between the two treatment arms. And that was to sort of not have any confounding factors while knowing what the real true alpha by beta of breast cancer and breast parenchyma was. Now, as the early results of FAST came in and we moved towards the fast forward protocol, by then the START study had published mature results, and we knew that this moderately hypofractionated regimen could be used as a standard, and hence the fast forward was not compared with 50 gray in 25 fraction, was compared with 40 gray in 15 fraction. So here you can see the 26 gray in 5 fraction or the fast forward protocol was not compared directly to 50 gray in 25 fraction, which is still considered fairly standard by most of us. And the fast regimen was not directly compared with the START B protocol or START B regimen or moderately hypofractionated regimen. And here you can also see that most of the results are displayed. So we have 10-year toxicity and locoregional outcome data of FAST, and we have 5-year locoregional and the toxicity data of the fast forward, and which is why today we are discussing all of these studies, so that during these COVID times, if we feel we can perhaps treat these patients with this particular regimen, we should. Now, moving forward, we also had safety data from the import high study, which showed that SIB or simultaneous integrated boost, wherever boost was indicated, was also safe, and which is why radiobiologically equivalent SIB doses in TMH are being used for these patients whenever they are being treated with the 5 fraction regimen. For fast protocol, we are treating with 33 gray to the tumor bed, and likewise for fast forward to 32 gray. Now, as I was discussing, the alpha by beta basically had the key and told us that there was further room for hypofractionation. And as you can see, mature data from the meta-analysis of START A study and the START pilot study showed that the for locoregional outcomes, the alpha by beta was 3.5, and that for the normal tissues was around 3 gray. So when you know that the tumor and the normal tissue have similar alpha by beta, and that too on the lower side, we know that large fraction sizes would be more effective without producing detrimental effect on normal tissue. But we did not know at that point in time that would ultra hypofractionation be safe. And just to answer that particular question, we had to move forward and conduct randomized study. Now, proceeding forward in this particular section, I would be constantly comparing fast and fast forward, because these are both two ultra hypofractionated regimen. Even though fast started before and concluded prior to starting of fast forward, I am still going to compare and contrast so that everyone gets a visual feeling of what exactly both of these cohorts looked like and what was the treatment like in either of these setups. Now, here you can see that FAST was a smaller study with 915 patients, whereas Fast Forward was a larger study with 4,110 patients. In FAST, as we've discussed, it was the comparator arm was 50 gray in 25 fraction. Now, at that point in time, since START A studies, mature data was not out, we did not know the true alpha by beta, but we did still have an idea that it was between 3 and 4. Two fractionation regimens were used. That was 30 gray in 5 fraction or 28.5 gray in 5 fraction, where 30 gray experimental arm assumed the alpha by beta to be 4 for late toxicity, whereas the alpha by beta for the experimental arm 2 was kept at 3 gray. Now, if they knew that if the alpha by beta was between 3 and 4, they could perhaps interpolate, and they chose these two smart fractionation. Whereas by the time fast forward was conceptualized, we already had the outcome data of and the mature data from the START studies telling us that the alpha by beta was perhaps closer to 3 than to 4. And that is when they had used the alpha by beta as 3 for the assumption. But nevertheless, they still had two different fractionation. As you can see over here, it was 27 gray in 5 fraction in 1 week, that is treatment finished daily over 5 days. And the experimental arm had 1 gray less, that was 26 gray in 5 fraction. And here, the first arm assumed no treatment time compensation. That means when you condense the treatment from 3 weeks to 1 week, it assumed that there was absolutely no problem radiobiologically, whereas the second arm said that no, because there was condensation of treatment from 3 to 1, we should have reduced the overall treatment dose, and that is why 26 gray in 5 fraction was used. In fast forward study, they were stratified by risk groups, and tumor bed boost was allowed. However, you had to mention prior to randomization what kind of boost you had planned for that particular patient. Now, looking at the inclusion study, FAST basically was a very safe study since they were venturing into untested territory and uncharted seas. They wanted to put forth this particular or give this treatment in extremely safe population, or what we call as our APBI cohort, more than 50 years of age, invasive carcinoma, all conserved breast, margin negative, T size less than 3 centimeter, or node negative. Therefore, they excluded everyone who had N plus disease or required tumor bed boost or had use of neoadjuvant or adjuvant cytotoxic chemotherapy. Whereas in fast forward, it was more all comers type of a cohort, more than 18 years of age. Any type of surgery was allowed, including oncoplasty, including whole breast reconstructions. Initially, they had taken only T1 to T3 and N0 to N1 patients where regional nodal irradiation was not indicated. However, moving forward, they also introduced the lymphatic arm of the study where supraclavicular and low axillary radiation was given. And therefore, you can see a star mark, and N1 to 2 was also included. The exclusion also included the safest cohort. So if you had 65-year-old T1, T2, T1 grade 1, 2, or ER/PR strongly positive, HER2 negative, micro-invasive disease, all of these patients were excluded from this study. And concurrent chemotherapy was excluded, and N3 disease, or those requiring IMNRT, were excluded. Looking at what was the primary and secondary outcome measure used in either of these studies. So you know that FAST was basically a dose finding study, or a study that wanted to closely look at the true alpha wave beta of breast and breast cancer. Therefore, the primary outcome was change in photographic breast appearance compared to baseline and 2 and 5 years. The secondary outcome, however, was also local tumor control, radiation induced changes in breast and other late responding tissues. Whereas fast forward was more pragmatic. For the acute toxicity pilot study, it was acute toxicity, but for the main study, the primary outcome was 5-year local relapse rates, and the secondary outcome was prevalence of late breast toxicities at 5 years, patient reported outcomes, and health economics, part of the 5 fraction regimen. Coming to the RT planning, both differed slightly in how they had approached radiation treatment planning. Both required the patient to be in supine position over a breastboard, or fast forward allowed a vacuum bag as well. Now, fast regimen allowed you to simulate patient using a conventional simulator also, whereas fast forward used only 3D CT based planning. That means everyone had to be planned using CT based planning. The CTV was contoured on both fast and fast forward, like the EORTC regimen, where you would include the whole breast up to the deep fascia, not include the underlying pectoralis or the rib cage. You have to remember that neither of these studies included T4, so that's why pectoralis was excluded essentially from all patients. A PTV expansion, 3D expansion of 1 centimeter was given, where the PTV was limited medially at the midline and laterally at the mid axillary line. And here you can see, because conventional simulator was also used, 2 centimeter max lung distance was allowed, and this was a very strong parameter used in quality assurance and quality checks run during the FAST study. The prescription point was also extremely important, and as I will show over here, so what they did was at the interfield separation, at the midway between the interfield separation, when you draw a perpendicular bisector, the distance, you also go halfway between the distance of from the lung to the skin, and at the midpoint of this you would place your reference point, or that would be your ICRU prescription point, and this was consistently used for all patients. And this was at the mid slice, or the slice of your isocenter. No cobalt RT was used, was used for either of. It was mandatory in the fast forward regimen to contour the ipsilateral lung and heart. For the lymphatic arm, they had also contoured the brachial plexus. However, they were even confident before beginning the lymphatic arm study that it would be safe because of the SBRT data being mature by then. The patients were treated mostly using bitangent radiation or field and field IMRT, and tissue heterogeneity correction had to be applied when you were planning. Now, just showing you basic examples of how contouring was done in fast forward study. So if this particular was your tumor bed and seroma, you would, for contouring the tumor bed, you would give 1 centimeter margin all around. And then you would use this particular PTV for your field placements. However, for dose reporting, you would again shrink it from the skin and from the lung tissue by 5 millimeters. Similarly, for contouring the CTV of your breast, you would contour just like the URTC guideline, skip it, contract it further from the skin, be above the pectoralis muscle as you can see over here, and then give it a PTV margin of 1 centimeter. You would use this particular PTV that is shown in yellow for your field placements. However, for dose reporting, you would further shrink it within 5 millimeters from the lung and from the skin. Now, one has to remember that when you're placing the fields, you should also take into consideration the penumbra margin and then place your fields so that adequate coverage was ascertained. Now, several of these patients were also allowed to have direct field-based treatment and not contour-based treatment. And just for dosimetric reporting, field-based contouring was also allowed. And as you can see over here, everything within the field had to be contoured, but you had to shrink it again by 5 millimeters from the skin and from the posterior edge of the beam. Over here, from the superior and the inferior end of your field, you had to shrink it by 1 centimeter rather than 5 millimeters. And similarly, for a patient, so this is for fast forward because fast did not include chest walls. So for fast forward patients, again, for contouring the chest wall, you would include everything that was in subcutaneous space right from the skin, but exclude pectoralis as well as the rib cage. Draw 1 centimeter margin around it. Use this particular for your PTV for your field placements. However, for dose reporting, if you were using bolus, you would not crop it from skin. You would only crop it by 5 millimeters from the lung. But if you were not using a bolus, then you would further go ahead and crop it by 5 millimeters from the skin as well. Similarly, if you were similarly like the conserved breast, if you were to directly place fields and you wanted still dosimetric reporting, then you would do a field-based contouring just like I had spoken about in conserved cases. Here again, you would crop from the skin if you were not using a bolus, or if you were using a bolus, you would not crop from the skin. Now, moving forward to RT planning, and this I'm talking purely for fast forward today. You could use 6 MV or mixed beams wherever necessary. So if you had a patient with higher interfield separation, mixed beams were allowed up to 15 MV. Field and field IMRT or 3D CRT was encouraged. Non-divergent. So if you were to use in the lymphatic arm where there's a beam match line between the tangent and the supraclav, non-divergent beams had to be used. So basically, you can use a monoisocentric technique or a couch kick. For the supraclavicular field, single anterior or angled field for supraclavicular field for SCFRT was preferred. And here the beam was angled to so that you would not overdose the midline structures like the spinal cord. All volumes finally had to be assessed the tumor bed, the supraclav, as well as the tangent or the whole breast. You did not have to report all of these individually, but in a sum plan. And you would do every possible thing like mixed beams, use wedges, use MLC shaping, use FIF IMRT, everything to try and achieve a tumor bed coverage of 95% of the volume receiving 95% of the dose, or for the chest wall and the breast, similar dose volume parameters. But for certain patients, even if after doing all these things, you did end up with underdosage, up to 90% of underdosage was acceptable. They had also strict criteria on hot volumes and overdosage, and these are displayed over here. They had also strict criteria on how the OARs had to be handled. For the chest wall, bolus had to be used for all fractions, and that was encouraged. However, if you were a center who traditionally followed using half treatment with bolus and half treatment without bolus, or some permutation combination like that, you had to inform them prior, and a separate type of QA had to be done for that. And both the bolus and non-bolus plans had to be submitted for quality assurance. Electrons were not preferred for treatment of chest wall unless it was really, really mandatory. For tumor bed boost, again, electrons were preferred. So off-phase electron, or then mini tangents or coplanar multi-field photon treatment, that is just 3D CRT in short. Or you could also use IMRT and VMAT, but it had a different set of quality assurance rules if you had to use either of them. Now, for setup verification and QA requirements were also stringent. For all these patients, for all 5 fractions, you had to use daily imaging using EPID, and it could be either KV or MV. And all displacements that were seen had to be corrected at each fraction. And despite that, after correcting, if you saw that there was more than 5 mm difference between between the images, then a repeat setup had to be done. Or if you felt that a resimulation was in order, then that had to also be done. Similar verification was done for all fractions if a conformal photon boost was used. That means if after treatment of your whole breast, if a sequential boost was planned for this particular patient, then, and it had to be done using multi-field 3D CRT or IMRT, then for each of these fractions, you had to use daily imaging. For electron boost, however, it was slightly better, where visual verification with skin marking was allowed. Quality assurance and credentialing of all steps of treatment were done. That means for contouring, treatment technique assessment, homogeneity of your plans, prescription point placement, the IMRT technique, everything, including assessment of daily QC protocols, whether it was machine-wise quality check or it was patient-based quality check. And a separate custom-made phantom was made, which was taken to each of these centers for quality assurance verification. Image verification protocols were also used. That means imaging not just for setup verification, but also imaging of your CT data set. In vivo dosimetry was done on the first day of the test arm and within 1 week of the control arm. So in short, these studies had sound hypotheses. They were well conceptualized. The fast forward study was well powered for all 3 endpoints. The fast study had extremely favorable patient population. The fast forward study had nearly all comers except lowest risk patients or the highest risk patients like T4 or N3 disease. And despite using the ultra hypofractionated treatments, the RT techniques that were used in these particular studies were the ones that we routinely now used for most of our patients in most centers. But one has to remember that all of this was done under strict quality assurance, and only then it was a successful multi-center study. And because it's a successful multi-center study, the results can be generalized at a later date whenever the results mature. Thank you.
Thank you, Rima. That was a wonderful talk, which very in detail you told us about the inclusion and exclusion criteria. And I think that's a very important part of this discussion, because we don't want to select patients to whom we cannot reciprocate these results into. So, and of course, the quality assurance parts of it. So we will discuss as we go forward about in which centers, which of these protocols we could use. So I would like to invite Dr. Santam Chakrabarti now to discuss the results with us of Fast Forward. Santam, over to you. Thanks.
Yeah, hello, good afternoon, everybody. I hope you can see me.
Yes, we can see the slide, Santam.
Yes, great, great. So coming to the results of the fast forward, I think it is always important to remember that the population on which this study is drawing from is primarily a screen detected Caucasian population, which will be primarily more negative. And this is very, very important to understand. So let's go to the next slide. This is a well-conducted study. As we can see, out of 4,110 patients, nearly 99.6 are available for an intention to treat analysis. So very, very few patients withdrew consent, which again indicates that they had taken their patient representatives in the trial planning, and this is something that we should learn from them. 98.7% of the patients received the treatment that were allocated, and 89% of the patients out of the intention to treat analysis actually have a 5-year visit. So it is not like a 5-year visit, which is a median 5-year visit. This is nearly 90% of the population has a 5-year visit in this trial. Coming to the next slide, if you look at the patient demographics, and I think I would like to draw your attention here, although this trial is supposed to be for all comers, the trial population draws from a population which does not have the high risk population that we see in India. For example, grade 3 disease, which you would probably have in almost all of your patients, accounted for less than 30% of the population. Slightly better than fast and import low, but nonetheless not more than 30%. 93% of the patients underwent breast conserving surgery. And if you look at the table in details, you will understand that most of them did not require an oncoplastic procedure. Now, this is also important because if you are in a center which sees a more locally advanced population of breast cancer, oncoplastic breast surgery would often be favored by your surgeon for a good cosmetic outcome. Only 15% of the patients in the trials had an axillary dissection, which is of course true in most of the Western world now. The sentinel node biopsy is taking over. And this is reflective of the fact that this trial was conducted at a later era as compared to FAST, where nodal dissection was done in nearly 30% of the patient population. Take a look at the median T size. You will see that the T size is around 1.6 centimeters. Not much different from FAST, that the median size is 1.3 centimeters. So although fast forward is supposed to be a study which takes in all comers, the median size was not so much different. And of course, you can see the T stage, T2 plus, is basically 30% of the entire population. Only 19% of the population is actually node negative, is node positive. And if you look at the NACT figures, they're less than 3%. So coming to the next one, 98%, 90% of the patients are ER positive, only 10% HER2 positive, and less than 10% triple negative breast cancer population. Again, an indicator of the population from which this is drawn. LBI positivity is seen in around 14% of the population, and nearly 1/5 of the population has undergone adjuvant chemotherapy. So what we understand from this is that the population is really at a low risk. If you look at the primary endpoint results, ipsilateral breast tumor recurrences occurred in only 79 patients in 5 years. The median follow-up is actually longer than that. And they were well balanced between the arms. In fact, the 26-ray arm had a slightly numerically lower number, although the hazard ratios are such that we cannot claim that they are superior. The cumulative incidence of local failure in all the 3 arms is quite low, 2%, 1.7%, and 1.4%. And from this result, they could conclude that the upper limits of the 95% confidence interval for the absolute increase in IPTR was less than 1.6%, which was the pre-specified threshold in the protocol. So what it means is that if the 95% of the absolute risk of the ipsilateral breast tumor was more than 1.6%, non-inferiority would not have been proven in this trial. Again, this is something that is important to understand. This trial is working in a population which has a very, very low risk of recurrence. And therefore, 1.6% difference in the recurrence risk actually represents an hazard ratio of nearly 1.8, which basically means that your trial is unable to demonstrate a non-inferiority of somewhere around less than 1.6 with this population. The critical hazard ratio of 1.8 is something that is probably practical, because below this, you would not be able to have a practical trial. They had done a per protocol analysis because this is a non-inferiority trial. It's consistent with the intention to treat analysis. What is important is that the hazard ratios from the competing risk analysis, which basically means breast cancer patients may die without a local recurrence. So if you do a competing risk analysis, you may find a different result. Typically what happens is that when you have a competing risk analysis, the risk difference will usually magnify. and they saw that the same hazard ratios are present. So again, what it says is that for this early breast cancer population, the non-inferiority of the two schedules in terms of ipsilateral breast tumor recurrence is proven. Let's look at the secondary endpoints. Regional recurrence, distant metastasis, and invasive contralateral breast cancer recurrence. None of them are any different between the three arms. And this is reflected in the disease-free survival and overall survival graphs. The 5-year disease-free survival and overall survival is in excess of 95%, which again indicates an extremely good prognosis of these patients. And if you look at the cause of death, roughly half of the patients in this population has died of non-breast cancer related disease. What about the recurrences of risk group? This is a busy slide, so I will take you through it. What is important to understand is that the factors which are real risk factors for recurrence, for example, grade 3 disease. See what happens over here. Grade 3 disease accounts for 28% of the population, but 54% of the ipsilateral breast tumor recurrences and nearly 60% of the distant metastases have happened in this population. Now, this does not mean that the trial arms are any different between the three groups, but what it shows is that if the high-risk population is underrepresented, you do have a lower chance of demonstrating non-inferiority, even if a true non-inferiority exists. Coming to the acute toxicity, this is a publication that was done a while ago in 2016. And we know that the 26-gray arm was associated with a slightly lower rate of skin toxicity, although the purpose of this analysis was never really to compare the three arms. But we see that overall, the rates of grade 3-4 skin reaction with an RTOG grading schema is really, really low. This is another important lesson and attests to the quality assurance that these investigators have achieved in their homogeneity of the plan. 6% rates of grade 3-4 reactions after breast conservation surgery are really low. Coming to the late toxicity, what we see is that 27-gray arm had a slightly higher hazards of developing late complication. But numerically, if you see, the risk is really low. For example, let's take breast distortion. The risk of breast distortion was around 4% in the 40-gray arm, 5% in the 26-gray arm, and 6% in the 27-gray arm. The hazard ratio boils down to 1.55. Again, this is a reflection of the fact that if your baseline risk is really low, the slightest increase in the risk results in a huge jump in hazard ratios. And the way these analyses are conducted, these will be statistically significant. But the clinical meaningfulness of these differences is possibly difficult to appreciate. They have done a quite comprehensive reporting on the adverse events. So, for example, they have done the physician-reported versions, they have done the patient-reported versions, there is data on photographic change. All of these show that the 26-gray arm is actually similar to the 40-gray arm as far as late toxicity is concerned. 27 is probably more toxic. And the reason for this is, of course, the way the breast tissue responds to radiation is probably not the way it was thought when fast forward was planned. So the take-home message, and I will not take any more time, is that the trial demonstrated non-inferiority when measured in terms of an ipsilateral breast tumor relapse between the two schedules as compared to the 40-gray arm in early breast cancer, most of whom were treated by local tumor excision and sentinel node biopsy from node-negative disease. These are not my words. These are the words of the investigators taken verbatim. The unadjusted alpha-beta ratio for tumor control is 3.7, slightly different from the start estimate. And as we can see, the EQD2 is 44.7, 43.1, and 40.6 for 40-gray, 27, and 26-gray arms. They have not really included the tumor proliferation in this calculation. Moderate to marked normal tissue effects, the alpha beta was around 1.7, and if we look at PROMs, the alpha beta was around 2.7. So this suggests that overall, the tolerance of the breast normal tissue to ultrafractionated radiation treatment is not similar to what would be there for more modestly fractionated regimens like 15 fractions. And this is another important point of caution that we should be knowing about before adopting this regime. Thank you. I will now switch over to Prasad.
Thank you very much, Santam, for this wonderful, detailed introduction to the results. Uh, Now, our previous speakers have alluded that these results are done in a very controlled environment in a Caucasian population in early stage. So, what we need to also look at is how relevant is this for us in the Indian context. So, to talk about that, I would like to invite Sanjay to share his experience of TMC, and then Rima will also share the TMH experience with us. Over to you, Sanjay. Santam, I think you need to, yeah, stop.
Hi, good evening. Can you see my screen?
Yes, we can see the screen, Sanjay. Yes.
Right.
Yeah, this is
Prasad, thank
perfect.
you very much for organizing this webinar. And you know, Rima and Shantam have been they've just pitched their presentation absolutely perfect. The way I thought I would address this is go back a few years, go back to 2010 and 2012ish, when we were just about in the crux of changing from the 5-week regime, the 50 gray in 25 fractions, which was the standard in India at that point, to a 3-week regime. And the 10-year control data from the UK START-B study came. And we were very assured to see that irrespective of age, irrespective of the type of surgery, the grade of tumor, where the chemotherapy was received, where the radiotherapy boost was given, patients with the hypofractionated arm seemed to be at least as good or doing as good as the 5-week regime. So we felt that the 5-week regime is at least non-inferior, or 3-week regime is non-inferior to the 5-week regime. Some of us, and that includes some of the major cancer centers in this country, had started moving on to hypofractionation prior to this publication, and we had done that after a lot of consultation, and we had written letter after letter criticizing and discussing, debating as to why hypofractionation could be good for India. And then we were relieved in 2012 when we published, or 2016 when we published a cohort of around 925 patient data, which suggests that hypofractionation, even in the Indian patients using a 40 gray in 15 fraction along with boost, is at least producing results which is as good as the START-B cohorts. So with that in mind, we all can conclude that breast cancers are sensitive to fraction size, or breast cancers are sensitive to a higher fraction size. However, just like my colleagues were alluding, the discussion should center around how do we pitch the hypofractionation to a comparative normal tissue tolerance, or how do we actually make sure that the hypofractionation is safe. So further hypofractionation was being looked at. Now, just a recap again. So 40 grays in 15 fraction was non-inferior to 50 grays in 25 fraction. And now we've just heard Shantam and Rima confirm that the 26 gray in 5 fractions was non-inferior to the 40 grays in 15 fraction arms. And this is non-inferior in terms of tumor control. We have the 10-year data from the start, which says it is at least non-inferior in terms of cosmesis, if not better. And we are waiting for the long-term outcome from the 26 and 5 fraction arm to say that the cosmesis remains better. But you know, you have to remember, just like Shantam was mentioning, the 27 gray in 5 fraction arm is also non-inferior. So why do we just give the 26 gray and why not the 27 gray? I tried to summarize this in this slide, which is a very simplistic way of looking at it. I must say, you know, we haven't taken the kappa value, we haven't taken the overall treatment time, we haven't taken the mitotic figures. But you know, if you look at on the left, the table actually tells you that for an alpha beta for 4, 3.5, and 3, the 3 regimes that were used in the fast arm, which is 50 gray versus the 30 gray, if the alpha beta was 4, then the BED was exactly similar, 75 gray versus 75 gray. If on the other hand, the alpha beta was less than 4, then the BED of 30 grays in 15 fraction using the fast regime, not the fast forward, the fast regime, was starting to get toxic. And if it is between 3 and 3.5, it would be significantly toxic possibly. Now, with that in mind, we believe that after the fast toxicity data said that the 28 gray in 5 fraction arm was better in terms of toxicity, we believe that the safer regime to use for breast was possibly something with an alpha beta of around 3.5 to 3. And with that in mind, if we go to the table on the right, which is the fast forward table, you can see that, between 3.5, 3 and 2.5 alpha beta, with the 3.5 alpha beta, the BED of 40 gray in 15 fraction and the BED of 27 gray in 5 fraction were pretty much similar, whilst the BED was exactly the same in 27 gray in 5 fraction and 40 gray in 15 if it was an alpha beta of 3, whilst if it is an alpha beta of 2.5, the BED is likely to be more for the 27 gray in 5 fraction arm. So given that we have a doubt whether the alpha beta of normal tissue surrounding and also for breast cancer control could be around 3 to just about less than 3, just around 3, it may be prudent to continue with the 26 gray in 5 fraction regime over here. The point that we have to remember over here is that small changes from 26 to 27 gray in incidence dose can actually lead to a significant NTCP change in future in 10 years. That is an hypothesis, not proven yet, but it is an hypothesis. So the fast forward summary, yes, is that the 26 gray in 5 fraction regime can be primarily used to treat T1 tumors, a bit of T2s less than 3 centimeters, possibly grade 1, grade 2, node negatives. Yes, node positives were included, but as Shantam showed, it was pretty minimal. ER positive tumors, strongly positive tumors. And there was strict quality assurance, as Rima was mentioning. And the biggest thing that you've got to remember over here is that there was gross and significant strict external peer review of the quality assurance by the RTT QA of the UK team. The dosimetry of most patients were between 95 to 105, 107 was taken in as the ICRU, and the maximum dose allowed was 110% as point dose. All patients in the fast forward were 3D CRT planned. So it may be used, but again, I say may be used, but let's move on and find out what the consensus document says. So the international consensus documents that many of us read about the COVID pandemic actually says, well, we can avoid radiotherapy in some who are over 65, and that comes from the PRIME 2 study, which says that the over 65, grade 1, grade 2, strongly positive women, we can actually avoid radiotherapy in them. But look at the point number 2. It says that one can deliver the 5 fraction regime, be it the fast or the fast forward, so 28 to 30 grays in 1 week, or the 26 gray in 5 weeks. But just look at the tumor type that they have selected, and these are the people that have actually participated in the study. So Charlotte Coles, the first author of this consensus document that we published, and it says that you use it if you have to in the node negative tumors that do not require a boost, So the 26 gray plus boost, they are still holding on as a standard treatment strategy. They're saying that boost could be avoided to reduce fractions at the time of COVID in the very low risk patients who are over 40 years of age. Now, with that in mind, let's look at our patient population. I go back to this paper that we published in 2016, and our mean age is 53. Systemic therapy received is around 100% of our patients who received either adjuvant or neoadjuvant systemic therapy. Surgery, breast conservation around 57, but around 50% or 60% in some centers would get mastectomies. Most of our patients are grade 3s. The majority of our patients are luminal Bs, HER2-rich or triple negatives, rather than the UK screen-detected tumors, many of whom are actually luminal A tumors. So with that in mind, let's try and see how we thought about tackling the hyperfractionation discussions and how we in Tata Medical Center, and then we joined up with centers across the country to try and see how we can actually address the issue of hyperfractionation in India. So whilst the fast and the fast forward were being designed, what we did in Tata Medical Center after the publication of our results of safe, moderate hyperfractionation of 40 grays in 15, we said that, why don't we see if it is safe to hypofractionate further in a group of patients who have advanced disease. If these people tolerate the treatment fine, if these people don't have a lot of toxicity, we will then move on to the adjuvant setting and expose our patients who have adjuvant radiotherapy. And you can see the rationale for the dose fractionation was pretty clear. So, with the EQD2 of 3, which we now believe is likely to be the EQD2 of breast cancers, the 40 gray in 15 fraction, and then there was a consensus that we had. Professor John Yarnold helped us with generation of this 35 gray in 10 fraction regime. I remember having discussions with doctors from CMC Vellore, from SGPGI Lucknow, and from TMH Mumbai, along with Professor Yarnold, to see whether this regime is safe in the adjuvant setting. And we said, why don't we test it in the palliative setting first, because of the EQD2, which is similar in these two groups. And we said that, yes, if we do the FACT-P scoring, if we do a response assessment clinically as well as metabolically, we may be able to prove that it is working, this regime works. And the initial data of publication of 30 patients that we used to treat with the 35 grays in 10 fraction, and we presented it in ASCO, we found that, yes, this is effective in reducing the pain. It is well tolerated, and the PHQ scoring system was significant improvement in 55% of patients. What was important is that there were no grade 3, grade 4 toxicities in these patients, and this is what we were trying to see. No grade 3, grade 4 toxicities, no brachial plexus problems in these patients. Many of these patients were node positive, and they received nodal radiotherapy as well. So we thought that the 35 gray in 10 fraction arm was really an easy regime to go with. Whilst we had confidence with the 35 grays in 10 fraction, we thought about further hyperfractionation, and we used the 26 gray in 5 fraction that the UK fast forward people have used. And we thought that, okay, we use the 26 gray in 5 fraction, but we have a tumor over here. Can we give a simultaneous integrated boost of 6 gray in these big tumors, the tumors that are big, which have cancer in them, so palliative tumors? Can we actually use them as a phase 1, phase 2 prospective study? And again, we used this in the 30 patients. We've completed recruiting. We presented the interim results. The patient, the trial schema was exactly the same as the first 30 patients. And we found, yes, most of these patients actually tolerated the treatment well. We did not have any grade 3, grade 4 toxicities, and 4 patients had grade 2 skin toxicity, so that we were confident that, yes, using the 26 grays in 5 fraction along with a 6 gray boost as a simultaneous integrated boost was actually safe in our cohort of patients. Whilst we were doing this, we were thinking of actually moving on to hypofractionation and SIV in our 3-week regime as well. So Shantam and I, what we did is we formulated with our physics team a stringent quality assurance policy, and we tried to actually integrate a 48 gray in 15 fraction SIV regime, which took us about 2.5 years. I must tell you, it's quite a tedious job to do to get a class solution for this. And a 48 grays in 15 fraction SIV regime was our standard that we now use in all our patients in the in Tata Medical Center. And with that in mind, we said, what about using the import B, using the experience that we've developed on hyperfractionation with 32 grays in 5 fraction? Can we actually formulate a study which we can collaborate across the country with? And we had consensus discussion with most people with interested people across the country. And we are delighted that Christian Medical College Vellore, Dr. Selvamani and team, Dr. Punita and team from SGPGI Lucknow, and the All India Institute of Medical Sciences in New Delhi and Tata Medical Center, we've joined together to formulate the Highport adjuvant study. So this study is looking at reducing the number of treatments to 5 versus the 15, integrate in a cohort, in the majority of the patients, integrate the boost within the treatment in the SIV arm. And this is the trial schema. 2,100 patients in a multicentric cohort will be recruited. Accrual period over 5 years, total duration of study over 10 years. It's a non-inferiority design. And we said we would not limit to the node negatives or the N1s. We should actually do it as a practical Indian study where we actually include regional nodal radiotherapy. where we actually include triple negative breast cancers as well, and we include mastectomy patients as well. So with that in mind, we had again calculated the BED that we would expect for standard and experimental arm for the SIB and the mastectomy patients. You can see over here that, you know, for the BED, if you've taken alpha beta of 3, you get a similar BED for the standard and experimental arm for the SIB. And you know, if you have an alpha beta of 4 or 3.5, which is unlikely now that we've got these results, it still would be a study that wouldn't be significantly non-inferior. So this is the eligibility criteria. We have patients who are more than 18 years of age, BCS or MRM, all patients who have BCS, all patients after NACT, upfront MRM with a Cambridge score more than 2, T3, T4 tumors or more than 3 nodes positive, we would include. Exclusion criteria, if there's any residual SCF or IMN node, because some of us use a boost in them and we did not want to have a boost strategy in this, a tumor boost strategy of residual tumor in this adjuvant trial. We did not include metaplastic tumors or DCIS, and if they had comorbidities that would interfere with the receipt of RT, we would not include them. We had a non-inferiority boundary of 3%, a control arm of 95% control rate, and an alpha of 2.5% and a sample size of 2,100. As I said, the accrual period was 5 years and the study duration was 10 years. And this is the team of people that we've got initially to join up for the Highport adjuvant study. We have recruited around 400 patients in this trial. Now, if you look at the 400 patients that we've recruited, and if you look at the fast forward cohort, Shantam, me, and the colleagues who are in the trial have actually sent a letter to the Lancet, to the editor, saying that, you know, how the Highport adjuvant study is different to the fast forward study. And you can see that the median age is different. We have almost double the number of triple negative breast cancers. We have significantly high numbers of mastectomy. We have significantly high number of grade 3 tumors, significantly high number of NACT patients. Median pathological tumor size is significantly more again. I mean, we are not talking about statistical significance. We are talking about just a gross significance over here. Lymphovascular invasion is much, much more in our cohort of patients. SCF radiotherapy is received in much higher number of patients that we treat, and IMN radiotherapy is allowed within our study. So whether we can use the fast forward in the COVID times in our patients is something that we have to debate significantly, because, you know, our patients are different. Majority are node positive, majority are younger, majority receive systemic chemotherapy, majority have lymphovascular invasion, and you know, a significant number of them would benefit from SCF radiotherapy and IMN radiotherapy as well. So whether we will use the fast forward regime in general, I believe that, you know, in Tata Medical Center we are not. But if you get a patient who is very keen to use it and fulfills all the fast forward criteria, and after discussing the pros and cons, I think that could be offered, but not as an institutional policy. That's the group in Tata Medical Center that worked tirelessly for developing all the high-end treatment that we have. You know, we have the radiographers sitting in the front row. They are the ones that do the daily image guidance. We have our fellows and the physicists sitting on the right back on the third row onwards. And they're really the heart of the entire fast forward type regime that we do. So the Highport adjuvant study that we've actually formulated, and Shantam, me are really grateful to the rest of our consultant colleagues in Tata Medical Center, including our surgical colleagues for supporting, and medical oncology colleagues for supporting this study. And you know, we have a fantastic team in a team from CMC Vellore, from SGPJ Lucknow, and All India Institute that are recruiting in this study. As All India Institute are actually putting it through the IRB. They're still not recruiting, but the rest have got it through the IRB and started recruiting. And we are open for other centers who would allow external quality assurance and peer review to approach us as a consortium where we can actually complete the study. Thank you very much.
Thank you, Sanjay. That was a brilliant overview of how different our Indian population is, and why we need to be very careful when we use the fast forward protocol in our setting, and that we should not generalize it. And it's amazing to see the sort of work that you guys are doing at Tata Medical Center. And I would like to invite Dr. Rima now to talk about the work that has been happening on hyperfractionation in Tata Memorial Hospital in Mumbai. And after that, we'll take questions. We already have a lot of questions coming up. So over to you, Rima.
Thank you, Prasad, once again. So Sanjay has brilliant experience because he's already conducting a randomized study on while using this particular 5-fraction hypofractionated regimen. However, our experience stems mostly from our a small COVID cohort, as well as some patients that we've treated using the fast regimen after the fast results were out, the 10-year safety results were out. Now, like Sanjay started with 2010 and 12, we were pretty skeptical in adopting the 15 fraction coming from the 25 fraction standard era. And at that point in time, also, I remember there were several debates in our particular hospital in the breast unit, whether or not hypofractionation in our type of patients would be safe. Several times the discussions went on that the alpha by beta of the patients that we see in India may not really be that low, and maybe closer to say 10 that was conventionally thought of, and which is why it took us some time before we started adopting hypofractionation as a policy in Tata Memorial Hospital. And by 2014, all patients started to receive the 15 fraction, that is the start B regimen, 40 grain 15 fraction. And these are some of the results of comparison of our particular 2014 cohort with 2013, where the standard was still 50 grain 25 fraction in conventional fractionation. And as you can see, the worst of the lot, the ones that had mastectomy, that means these are usually the T3s and T4s and sometimes N3 disease patients that even after neoadjuvant chemotherapy, which is currently standard for LABCs, did not regress enough to undergo a breast conserving surgery. And these patients also at 5 years did not show any difference in our cohort between either of the fractionation regimen. And that sort of gives me some hope that even the ultra hypofractionated regimen will not likewise hamper the results of our patients if used judiciously during the COVID time. Now, one has to remember that several COVID guidelines came in before, while we were battling this at our home front, and most of these guidelines suggest that you could either use 28 gray to 30 gray in 5 fraction using the fast regimen or the fast forward regimen. And some guidelines go further up to say that you can even use a pre-operative radiotherapy if surgery was not done or if surgery was getting delayed. Now, we have to remember that, yes, like Sanjay said, that we don't have level 1 evidence in all patient subgroups to tell us that this particular regimen is safe. But one has to remember that if we don't offer radiotherapy, several of these patients will go without undergoing radiation at all because of the COVID outbreak. Now, like I mentioned, in TMH, we have our current standard is to do daily quality assurance. So it's a machine-specific QA that's done for all LAs. We have patient-specific QA for IMRT and SBRT patients, which is done for all of these patients prior to starting their treatments. Monoisocentric technique has become our standard for all patients that require regional nodal irradiation, and therefore we are pretty sure that we do not have match line issues. We have cross audit of more than 95% of the cases. So it's an internal cross audit. We don't have an external cross audit, but we do have more than 95% patients which are audited by either of us, either Dr. Sareen, Tabassum, or I. We recently conducted a retrospective study of 100 cases which have already been treated using field-based treatments, and not a single patient had a mean hard dose of more than 3 gray. And most of the patients that were treated with field-based PTV had a PTV coverage of 95%. Now, pre-pandemic, once the fast results, mature 10-year data was released in 2018, in patients with compelling reasons, that those patients that cannot travel daily, or those that were extremely eligible or favorable cohort which fit in the FAST study criteria, were being offered the FAST 5-fraction weekly treatment. During pandemic, however, with the lockdown that is in Mumbai, I'm not certain about all the parts of the country, but in Mumbai we have some serious number of cases, and that meant that we had severe restrictions on travel, and our treatment capacity decreased to less than half. And because of that, we could not treat a lot of we would not have been able to offer radiation to a lot of our patients. And hence we decided by March 15th that we would broaden the criteria for offering fast protocol based treatment. And by then, fast forward, only acute toxicity results were out. So we started offering it to patients who were more older than 40 years, T3 or up to T3 and N2 disease, but not T4 and N3. But by April 20th, when all the international COVID guidelines started suggesting that patients could be treated with 5-fraction regimen if situations were such where they would have otherwise not been treated with radiation at all. And hence, by April 20th, we started offering this to all the patients except those with recurrent disease or re-irradiation setting. Now, fast forward study was published on April 28th, and after that, our mastectomy patients, as well as those with PTV tumor bed volumes less than 100 cc, have been offered fast forward based treatment regimen. Now, this is the kind of data we have. We have treated so far 99 patients with fast-based regimen and 21 patients with fast-forward. And most of the patients where tumor bed boost is required in these patients, it has been given as simultaneous integrated boost either with IMRT or with electrons. Here you can see that it's a mixed buffet. It is all comers. We have not selected our patients. For the initial cohort, yes, we were strict in selecting the patients that entered fast treatment. However, now we have liberalized and we offer it to everyone. So you will see there are significant number of patients in the fast forward criteria that have T3 or T4 disease or N2 disease. Many of them would have received neoadjuvant chemotherapy or hormonal therapy. We also have significant numbers of HER2 positive and TNBC patients. We've also included both mastectomy as well as breast conserving surgery, and included patients with oncoplasty as well. We have treated a couple of patients with whole breast reconstruction as well, and they have also had absolutely no difference in acute toxicity. When we see the type of treatment, that the technique we have used, most of the fast patients were treated with IMRT, a third were treated with 3D CRT, whereas in fast forward, as you can see, we during the COVID era, where we would like to reduce the complexity of the treatment that is offered, we are offering more 3D CRT than IMRT, and tumor bed boost I have already alluded to. Now, these are just some examples of how we have adopted or how we give simultaneous integrated boost to these patients. So if this is a particular tumor cavity, we would give bitangents as routine. So a patient would receive 5.4, 5.2 or 5.7 gray of the whole breast dose using a bitangent. And then followed by that, we would either give a 3D CRT, IMRT, or electron-based treatment to the tumor bed. With 3D CRT and IMRT, you would have more conformity to the tumor bed and less high dose spillage or hot volume spillage through the breast. And with electron, the same thing, you would have a little bit higher volume of high doses, but within the current circumstances, this is acceptable. Now, these are some patients, and I have especially highlighted the first patient where we have treated this patient with small separation on cobalt as well. As you remember, in my inclusion, exclusion, or planning study, I had told that cobalt was absolutely not used. But for patients where you do not have hot volumes, or where you see that they fit dosimetrically within the criteria, you can use cobalt. So this patient was treated whole breast on cobalt, whereas had to go on to a LINAC for the electron boost. And this is the cumulative dose wash over here, isodoses. Similarly, we have also used for patients with mastectomy, and this is a isodose volume that you can see over here, which is 95% per 26 gray volume. We have used IMRT for tumor bed boost, and as you can see that the spill, this is the 107 for the whole breast volume, is only around the tumor bed and not within the rest of the breast parenchyma. Some guidelines, as I already showed, also suggest that for patients with IMN, you can use 5 fractions at this point in time if you can adhere to the strict dose volume parameters that were suggested in that particular paper. And we have been able to treat during these compelling times patients with IMN as well, and only in those patients where we could restrict doses to the ipsilateral heart and lung. Coming to acute toxicities, it's a fairly safe and gentle treatment. However, as you can see, this is the highest grade and seen in only one patient at the bottom right corner of my slide, this one. And this too healed without moist desquamation. Here you can see that most of the patients have either grade 0 to 1 toxicity, both in the lymphatic arm as well as the skin toxicity. None of our patients had grade 3 or grade 4 toxicity. That means none of our patients had a moist desquamation. And just coming, humoring myself on the economic impact. So if, and this is not at all to kind of justify this particular fractionation to be used on daily basis, but if I had to consider how much it will impact if we had to move on in future to 5 fractions. So now if you consider several of our private hospitals are wary of using hypofractionation, thinking that they would lose money when they convert the patients from 25 fractions to 15 fractions. Here you can see that if, so this is just a example that I'm giving. If a hospital has this particular pay structure for a particular patient radiation treatment, where you have separate professional hospital charges, CT planning, TPS planning, review and per fraction charges, then for 25 fractions, for if you were treating 10 patients per day for 1 month and 5 fractions per week, that means conventional fractionation for these 10 patients, in a month you would have received a revenue for these 10 patients of around 14 lakhs 20,000, and these patients will still be on RT because they are in the 4th week of their treatment and not the 5th. While if you were to treat these patients with hypofractionation, which is also an alternate standard in 15 fractions, over and above of the 10,79,000 that you would have generated from the first batch, by the week 4, you would have got 10 new patients, which you would have treated for 5 fractions within the first month, and you would have generated around 18 lakhs 20,000, which is higher than 14 fractions. Jumping onto the 5 fractions, now one would say that 5 fraction is way too low, and per fraction, as you can see with 25, you're getting 85,000 per patient, and here you're getting a measly 17,000 because the fraction number is so low. But just as you go forward, per week you would be able to treat one full set of 10 patients, and you multiply that revenue by 4 times, because in a month you have 4 weeks, and here you can see a staggering doubling of your treatment, of your revenue. And here, which means that whether you take 3D CRT or whether you take IMRT, your revenue doubles if you were to treat patients with hypofractionation. And this is also to be kept in mind, that you would also be saving the number of fractions, you would be saving that much of electricity and all those things, which I have not even taken into consideration. So the benefit of ultra hypofractionated RT during COVID are several. Here, for both patient and hospital, reduced hospital visit means reduced infection risk, and for hospital, it also means reduced PPE use. For patients, you will reduce the expenditure on stay and travel to the hospital. You will lower the toxicity. That means there are lower expenditure, lower hospitalization rates for acute toxicities. You will improve the access to RT without compromising outcomes, and you will increase acceptance to BCS. Now, this is a vague point. Acceptance to BCS is probably more to do with when it would become a standard of care, or it will at a later stage. but it will reduce treatment interruptions. Now, with the kind of lockdowns that we have, several of our patients have sometimes been able to come, sometimes not been able to come. So these type of treatment interruptions will be lower if you could finish your treatment within 1 week. And the improved quality of life is priceless. For the hospital, you would increase the number of patients that can be treated in the limited hours and resources that you have. I know of several hospitals that are closing and opening because of the infected patients. And this type of treatment regimen is vital to be used in these particular times. There'll be improvement in quality of treatment because you would be more careful while using higher doses per fraction. And just again, at a later date, you will break even earlier. So in summary, yes, ultra hypofractionated breast RT is feasible even in a high volume busy center like ours. Our initial experience is satisfactory. It's a resource intensive treatment. Like I said, you have a lot of quality assurance. If it's already built in your system, it's easier for you to adopt. But if not, then you will have to go through a big circle. Like Sanjay pointed out, it takes about 2 years, sometimes 3 years to bring in that kind of systematic change in your department. It is resource sparing in the long run and revenue generating if one sees it that way through that lens. With lockdown, reduced machine space and time, I think it is a fractionation that you may be able to use, especially when you're given an option of no RT versus giving some RT or giving the RT that you think can benefit. It could accommodate more patients, including those where chemotherapy was deferred. Logistics and finances for some favor once a week fast protocol, wherein patients can come only once a week. And for some patients who are here from outside and have to finish their treatment fast before they have to go back, then a fast forward RT may be more favorable. And concurrent, we've seen that concurrent tamoxifen and trastuzumab did not show any acute excess toxicity, and acute toxicities were manageable. And therefore, we also say that the 5-fraction regimen can be provided if the center meets all the above criteria. Thank you.
Thank you very much, Rima, for that excellent presentation and a very pragmatic sort of outlook towards what we are going through. Um, I'm sure we have lots of questions coming up, and I'm going to sort of project some of those questions. I'm not sure if we have time to answer all the questions, and some of the questions have already been answered. So I'm just going to share my screen and show you the questions which I have sort of selected in the sense because they have not been answered yet. Okay, can you guys see the screen, the Word document?
Yes, we can see.
Okay.
Yeah.
So let me start, and the panelist, whichever panelist wants to answer, please go ahead. Ajay from Amrita has asked question that PROM and photographic sub-studies had lesser number of patients. So can it be said that it's not sufficiently powered to detect difference between 26 and 40 gray? And also the photographic breast changes were numerically more in 26 compared to 40. So what's your opinion on this?
Okay, so I can take this. I agree with him. And this is something that is quite common. Actually, PROM studies are always very difficult to do. But what we have from the current data is that it is really not suggestive of a huge difference because the baseline number is so low. If you look at the 40 gray or the 26 gram, it's really, really low. So I don't think that we will have a study which can be dedicated to prompts per se or photographic market changes. We have study from FAST, and if we combine the results from it, I think the results are sufficiently okay that in terms of 26 gray versus 40 gray, we should not anticipate a huge difference. That said, it is difficult to understand what is going to happen in the setting of patients who have, say, an oncoplastic surgery done because these patients were not really represented in the trial population. There is a dearth of patients who have undergone mastectomy and reconstruction. So all of these things will be subject to further studies, and I'm sure the investigators will be studying these further. We also have PROMS outcome in our study, so this is something that we will be building on.
And now more and more surgeons are actually going ahead with oncoplastic surgery. So we
Yeah,
need to keep that in mind as well.
absolutely. The boost is something that is very important when you are doing oncoplasty. And typically, if you are doing boosts with oncoplasty, you would see that the volumes will be significantly higher.
Yeah.
Using simple techniques like in-phase electrons often is not sufficient when you are using oncoplastic techniques.
Yeah, absolutely. The second interesting question he has is since the rate of recurrence was very low and toxicity was almost the same, should we further reduce the dose in these patients?
Actually, the real question to ask would be, should we omit radiation at all?
I agree.
I don't think
On
it's of any consequence really reducing the dose by 1 gray further, because it will not make a huge difference in toxicity. But it's very clearly apparent that most of this population is actually the import low population. And if you see the prime 2 results, I'm pretty sure most of these patients would fit into the category where radiation can be avoided. Now, that said, it is a decision making that is shared decision making, because no matter how you look at it, we know that even prime 2 was a negative trial. It did show that local recurrences could be effectively reduced with radiation, and that is of significant importance to many patients, although we think it may not be.
Yeah. He again asks about the infrastructure, and that I think you have alluded that only centers which have the infrastructure for 3D planning and image guidance should be doing this.
I think he has raised a very valid point.
Hmm.
This is very, very important. If you do not do CT-based dosimetry, you have no idea what is happening inside your tumor volume. Just putting a single slice in the midline and thinking that that will cover the entire breast dosimetry is inadequate. So if you are planning to adopt a fractionation regimen, in fact, if you are planning to breast radiotherapy in the modern era, you should be going forward for 3D planning.
Absolutely.
I think
Absolutely.
this is an absolutely important point to be raised, and this is not just for 5 fractions. Even in future, when you go back to conventional treatments, even 25 fractions, I think it's absolutely essential that you move forward into CT-based planning and not to conventional radiotherapy or 2D-based planning.
Yeah, yeah, absolutely.
And the last question, I think there is no data on that.
Yeah, yeah, because many of
Yeah,
us
we don't use
empirically
that either.
use steroids, but yeah, the practice varies with various centers. Some of the questions have been already answered, so I'm sort of skipping them. Ajay has also asked, was the max mean hard dose which can be accepted with fast forward protocol? And many centers actually don't do DIBH or ABC. So, what's your view, or should we stick to the guidelines that are set by the protocol itself?
So the
It's
guideline did not say anything about the mean, or the protocol did not mention anything about the mean heart doses. But as I had shown in my presentation, the heart 1.5 gray and 7 gray dose volume parameters were shown. They have to be used, and the fast forward protocol is freely available for anyone to download from the internet. And if you are using fast forward treatment, and I would suggest you should use those dose constraints and adhere to them pretty strictly.
Yeah.
If I may say that actually, if you look at the importance of adhering to dose constraints to the heart, we have a publication on the cost effectiveness of DIBH, which is basically a publication on how cost effective it is to reduce the dose to the heart. You can look it up we can share with you. And it suggests that in India, if you look at the Indian population, because primarily it is such a young population, sparing the heart makes a huge difference, and it is significantly cost effective.
Yeah,
You may not have
absolutely.
ABC or DIBH, but adhering to heart constraints, even if you are doing the standard hypofractionation now, is very important.
MLCs, just
MLC is
shielding of
blocking
heart.
whatever, yeah.
Yeah. However, I have a question to ask. During the COVID, like we use DIBH for all our left breast cancer patients, but during COVID, we have sort of stopped doing that because the major problem that we faced was we were calling the patients repeatedly for trainings, and also the treatment time was longer. So we have decided that as of now, for next couple of weeks, we are going to hold on to the DIBH treatments and convert all of them to regular. However, keeping the breast, the heart dose in mind, what is the practice that your centers are using on this?
So in TMC Kolkata, I can answer that we are still continuing with DIBH treatments. That said, our COVID population is not high, but we do not foresee a huge difference in the way that we implement DIBH in our setup.
Okay.
So if at TMH in Mumbai, because we have a very high infection rate, and like I've alluded to, we treat fairly small number of patients as compared to what our capacity is. To economize on machine time, we have not been using DIBH. And I also think that using ABC might not be safe, because you would have a lot of aerosol generation and contamination of the area if that particular patient was asymptomatic and positive. But with RPM, if you have the machine time and if you have the capacity to treat, you can continue treating with DIBH also.
Yeah, absolutely. And in Mumbai, we are really struggling. We are seeing a lot of asymptomatic patients who are then turning out to be positive. So that's a real concern from ABC point of view. I completely agree.
Yes.
Sayan has asked, results show a steep dose response curve for late toxicity between 26 and 27. So then how safe is it to use an SIB for tumor bed?
I think that's an excellent question. And I would say the answer is that we don't know. And that's why we need to have studies on this.
Yeah, I would say it's an excellent question again. But again, going back to the start A, start B studies, you saw that there was also difference between the different fractionation used in start A, start B as well. But the import study showed that SIB was safe. Now, again, when you give a very high dose, or even for that matter, between 26 and 27 to the whole breast versus giving it to a smaller volume, I think that also may be a reason why it may turn out to be safe. But yes, we need prospective studies to look at it, and maybe Highport and our sharp study, which is in the making, will answer that particular question.
Okay. Sayan has also asked a question regarding the rationale behind the conventional fractionation for tumor bed boost. But as we learned from the panelists, that I think we are not using the conventional fractionation for tumor bed boost. But what is your view on this?
So
So
we've
I
not
think that
been again. Uh,
Yeah, I
Let me
think from
go
a
first, and
design
Shantam, you
perspective,
can
it makes
probably
for a
also.
very clean trial if you do not test two different things in the same study, because then ideally you would need to have a crossover design. So scientifically, a study like this makes more sense, where you do not test a boost regimen also, whose late-term toxicity results are not well known. So that's from a scientific perspective.
Okay. Rosina has asked that if we had moved from 50 gray to 40 gray by start trial results, while no one had done a trial like this in Indian population, why should we wait for why should we wait for 26 gray Indian trial? Very
I'll
question.
take this question. It's a question that is loaded. Rosina works in my center. I know exactly why this question is
And she's
asked.
also a co-author,
Oh
if
yeah,
I'm
oh
not
yeah.
mistaken.
Rosina, I think the table that I showed you with the difference between between our patients and the patients that are treated in the fast forward actually answers your question as to why we are not automatically moving through, and also the fact that we are actually giving our patient a simultaneous integrated boost, like Shayan has very nicely asked as to why would it be safe to give a SIB with a 5.2 gray fraction, a further SIB. Yes, that is what we are testing. That is why we are not ready yet to move on to the 26 gray as a routine treatment out with exceptional circumstances.
Okay, thank you.
And the other thing is, I would also like to add to that is, Rosina, for 40 grain 15 fraction for ages, Canada and UK were using this fractionation, and they had long-standing retrospective results. Whereas for these two fractionation or ultra hypofractionated treatments, we have just a small French study and some other elderly population studies to back it, and no long-term data. And that is why it's not fair to say that we could perhaps, even in centers which have strong QA programs, we can just easily adopt hypofractionation or ultra hypofractionation as a routine treatment.
Okay, thanks. So we have lots of further questions also. I'll just quickly read out to them.
Prasad, I saw a question from Tabassum. Can we?
I'm just trying to find that question. Yeah, I think because I copied all the questions that were posted till then, and then I'm just trying to find questions below that. Tabassum, yeah. Does volume of tumor bed impact choice of sequence of tumor bed boost?
Tabassum, what we do is not the volume, but rather the position of tumor bed. So if it is an extremely medial tumor bed, using a simultaneous integrated boost using the ARCs, the class solution that we published is pretty difficult. So we use electrons or in them. Otherwise, we do tend to use the arcs. If it is a central tumor or if it is any other quadrant apart from the extreme medials or the laterals, it is quite easy to use the arcs for the simultaneous integration. Otherwise, the PED program boost has been something that we've been using for a long time, so not an issue. So you can use this, as you know, you can use this anytime.
Okay. So Rosina has
And
again.
Sanjay, just like you had you have issues in medial and extreme lateral position, not so much in extreme lateral, but definitely in the medial position. Even when you don't use the class solution and you use full arc or partial arc based IMRTs, you do end up getting higher heart doses. And I guess in those particular patients, we also prefer sequential treatments.
Yeah, I mean, rather than the higher heart, I think a contralateral breast dose is a big challenge in them. So
That too, that too.
Rosina has again raised a very pertinent question, which many of us have in our mind. I said, if you don't consider the COVID issue, can we use this in node negative, non-grade 3 hormone positive patients?
this is something that I must take. I think Rima has given her point that, she has used it in TMH. The biggest challenge I find is that, half of our patients anyway get the 5 fractions because they're in the hypoadjuvant. So half of these patients get the 5 fractions because they're randomized into the 5 fraction anyway. Yeah. So for the patients who are grade 3, which is, grade 1 or grade 2, who are node negative, who are strongly ER positive, and who do understand that, we don't have India specific mature data. Of course, you can offer them to the patients, but saying that, it is not a standard policy that we use in Tata Medical Center. Rosina and me, we discussed this. It's good that she's actually bringing this up in this forum so that all of us can actually give our views. It is a very conservative way that we look at it, because we feel that, it has to fit all the criteria for a study for us to prescribe that dose fractionation. And we have to remember that Tata Medical Center actually gives a simultaneous integrated boost, by reducing the patients coming in for the external, for the adjuvant boost that they have to. So giving a simultaneous integrated boost along with 26 grays, even in those group of patients, could be a bit far-fetched, given that the Highport adjuvant trial results are not yet published. So I believe that it may be a bit risky. I wouldn't say risky, or a bit less evidence-based or to offer it. But if someone really cannot come, if it is an emergency situation, what can you do? You do discuss with the patient, give a high-risk consent, and you do offer it to them, but definitely not as routine.
But Sanjay, I would like to just add over here, if the patient actually fits the classical definition of fast protocol based fast patient cohort, then there is absolutely no harm in trying to treat them with that particular therapy, especially when you have 10-year local recurrence as well as toxicity data, both suggesting that 28.5 gray is equivalent to 14. And
Rima,
like I said, if it's between choosing a patient takes radiation versus not, you should definitely give this as an option.
right, Rima, I think we can debate on this for quite some time. I think the biggest challenge is we are in a privileged position that we have a randomized controlled study where half of our patients anyway are getting the 5 fractions, which most centers don't. In patients who are out with this study, whether we give this patient a 5 fraction regime with a SIB, which we do, give an SIB, there is absolutely no evidence that is available over there that says that 36 grays in 5 fraction is safe. And, majority of our patients do get an SAF radiotherapy. If on the other hand, you have patients who do not need SAF radiotherapy, small tumors, ER positive, you can just give a 26 gray in 5, patient is over 50, don't need to give a boost. Yes, of course, you can offer it to them, saying that, we don't have India-specific data, but there's an international consensus guidance on it. Of course, you can do that in selected groups, but
Of course, that population actually probably may not need radiation.
I was waiting for you,
but
Shantam.
Shantam,
And also, they would often fit into a partial breast criteria.
Shantam, let's not get to that extreme. I think, for the purposes of this webinar, we can say that, yes, we can offer radiotherapy in that very small group of population after taking a higher risk consent. Because, if you have a patient who you can omit the boost, just like, the recommendation from, if you look at the recommendation in the entirety. The recommendation is the 5-fraction regime should be given to patients who do not get a boost. Now, if you have a patient who does not need a boost, who does not need SCF radiotherapy, IMN radiotherapy is strongly ER positive, is grade 1, grade 3, of course offer it. Now, if you say that, without giving anything, can we not give something? Of course you can. Make sure that whatever you're giving is safe. As a doctor, the first thing we do is we ensure the safety of our patients. Now, if we say that, yes, the radiotherapy we're giving is safe, and if you have evidence to prove that, yes, that is safe, well, go ahead, do it. If you do not have evidence, Tata Medical Center would usually struggle doing something that is less evidence-based.
So I think it's a battle between pragmatism and evidence-based medicine. And in current days that we are living in, it's a little tricky to choose between the two. And we can debate this, as you said, for a long time. Dr. Sareen has made an interesting point that patients who live outside Mumbai generally prefer fast forward, while patients who are from the city would prefer a fast protocol, because then maybe they could come up on Saturday and take the treatment. Yes, that's really interesting, and we should in fact think about offering those sorts of protocols to those patients.
Dr. Sareen has actually got this hypothesis, and I think there is a study that we are all looking forward to that he's bringing up with the fast type protocol. I think his hypothesis of patients coming in once a week is more convenient, is something that we also look out for. So yes, his study is something we are all looking up for.
So there's one more question which basically says that ultra hypo RT that is not achieving heart and lung constraints usually do not achieve conventional fractionation constraints also, because the problem essentially is the anatomical problem. So it doesn't matter what sort of constraints that you are trying to achieve. So what do we do in that setting?
Well, you can't change the anatomy of a patient. You've got to do as best as you can, isn't it? So you've got to get there to the Alara principle and get as low a dose to the heart as you can.
But then do you prefer a conventional fractionation, or would you then move?
Well, none of us are doing, I think Rima's first slide was very, very good. I think, none of us are recommending conventional fractionation.
Sorry, I mean conventional as in, say, start.
Yeah, so basically the start versus the 26 gray and 5, I don't believe that there's going to be much of a difference. Possibly the absolute dose is going to be lesser if you use the 26 gray and 5. So possibly the difference is going to be less if you give a lesser dose. The dose to the heart the mean heart dose is going to be lesser. Yes, so if you can plan your radiotherapy to the best of its quality assurance, so
Actually, that's a very pertinent point, because in our practice, even just because of the COVID situation, since we are offering it to almost all patients. Yeah. But when a patient does not kind of fulfill the dosimetric criteria in 28.5, we usually step down and bring it to 26, and we try and see if the patient is able to kind of fulfill the dosimetric parameters and constraints at that point in time. So we rather go in the opposite direction than what is being suggested, because of the total dose being lower.
So Kanu has asked, is it justified to give supraclavicular and axillary radiation with 5 fractions?
Excellent question from Kanu. I think the evidence is pretty low over there, and that's why we would wait for the Highport adjuvant study to be published before we do that.
Yeah. But just to again point out, we have several SBRT series from lung that suggest that 5-fraction treatments of much higher doses are safer. And if you can safely reduce your doses to brachial plexus. I don't think it's a challenge. We've
Rima,
had a few patients.
The basic difference between SBRT series from lung and what you treat with radiotherapy to the breast is the volume that you're treating. That is the biggest difference. And the volume effect on brachial plexus is likely to be significant. People were actually
Sanjay, our total doses are also fairly low as
no,
compared to what we treat in SBRT, and I feel that there is definite balance here. The lymphatic arm that has accrued, even though not published, they have safely said that none of their patients had brachial plexus in personal communication, and I don't think there's a grave worry over here that it will really end up. I mean, patients will end up having brachial plexopathy. Even if you see even if you read the protocol closely, they have mentioned that they are not expecting any patient to develop plexopathy in their particular cohort.
well, if you
Rima, I have a point actually over here. When you are talking about lung SBRT, you are talking about median survivals in the range of 3 to 5 years. When you are talking about breast adjuvant radiotherapy, median survival extends beyond 10 years.
No,
And we know
I
this is a
completely
long-term company.
I
So
completely agree there.
I think at this stage we should be safe and say that we do not have data. That's what we should say.
Perfect. So Dr. Sareen and Tabassum made some really interesting, pertinent comments, but we are really running short of time. So I'm going to take just two questions at the end. One is a very provocative question by Suresh, who says hypofractionation is tried for patient comfort, but how do we solve the package issues by government? So, and not just government, but even at some point, the insurance companies are also going to jump in. Rima has presented the economic parts of it, but do you guys have any sort of
The only issue with the economic model is that you need to have a waiting list of patients for it to work.
Yeah. And the last question that we'll take is any comment on single fraction coming up in future?
Yeah, that's
There are
definitely a
several
question for people.
studies actually.
Yeah. So I think we are at like 1 hour, 40 minutes or so in our webinar, and it's been amazing discussion. And thank you very much for Sanjay, Rima, and Santam for this, sparing your time, taking the time to make these slides and having this wonderful discussion with us. It is very
Thank you.
important for all of us to be pragmatic at this time, but at the same time, do not forget the basic tenets of evidence-based medicine. While we are all excited about 5 fractions, we need to remember that the patient population in that trial is actually very different from the patient population that we see. So to summarize, I think I can safely say that it is patient selection that we need to be very, very sure about, the quality assurance that we need to be very careful about, and the resources and the experience that we have. If we don't have, for example, resources for image guidance, then it's very tricky to move on to these fractionation, and also the expertise for QA and therapy. And Sanjay mentioned about the role of physicists and therapists in this, and they, I completely believe, play a very vital role. I mean, no matter what sort of beautiful plans that you may have clinically for patient, but if they're not executed the way they are to be executed, it's all down in the drain. So I'm sure many of us have learned a lot of things about this, and the take homes would be, each of us will have to really look at the resources that we have and the patient population that we have, and take a call depending on that whether we need to move to ultra hypofractionation or not. And also in the city that you live in, like in Mumbai currently, we are we are in really big crisis. So the pragmatism needs to be carefully managed with evidence-based medicine. We will be sending you some resources at the end of it in terms of the original fast forward paper as well as the contouring guidelines. All of you who have registered will receive them. Thank you very much again for the panelists for joining, Dr. Rima, Dr. Sanjay, and Dr. Santam. And thank you very much for all the participants who joined for this webinar. Thank you. Thanks a lot.
Thank you very much.
Bye.
Thanks.
Bye.
Thanks.
Bye.
Bye.